Welcome to Critical Care Time, the podcast for everyone who cares for the critically ill. I'm your co-host, Dr. Cyrus, here with my dear friend and co-host, Dr. Nick Mark. Nick, I think I can speak for both of us when I say we are super excited for this episode. We're taking a little departure from our usual approach here on Critical Care Time. It's a bit of uncharted territory for us today. Nick, do you want to tell the audience what I'm talking about?
Absolutely. Well, thanks, Cyrus. Great to be here. And yes, we're going to take a little bit of a detour from our regularly scheduled programming to talk about the philosophy of bedside rounds in the ICU. So instead of our usual physiology approach, referencing equations, citing papers, instead we're going to focus more on pedagogy. And we're going to share some of our own experiences and reflections, thinking back to yesteryear when we were not leading rounds, but just sort of on rounds, and how those experiences have kind of inspired our own approach to leading rounds.
I've had a lot of folks approach me, and Nick, I'm sure this has happened to you as well, who've kind of asked a little bit about our journeys, our own educational experiences, our approach to rounding with the team, et cetera, et cetera. And so this is our opportunity here in the holiday season to give a little gift, so to speak, to our listeners who might be interested in that sort of thing as they're sort of framing their own approach to critical care. So with that, sit back and relax as Nick and I throw around the old cognitive pigskin, take a few quick skips down memory lane, and share with you guys our thoughts on rounding and ICU education. So, Nick, why don't we kick things off with a question? I was kind of curious for you what your experience was like as a fellow as far as education went, bedside teaching, what was great about it, what wasn't so great about it. Why don't you, bring me up to speed on what life was like for a younger Nick Mark?
Yes, so a younger, less gray version of me. I have very positive memories of fellowship. You know, I got to work with some amazing people, amazing co-fellows, amazing, really inspirational attendings. But one sort of not so amazing aspect of academic medicine rounds is their length. And, specifically just like the pain of 5 hour long ICU rounds, spending half an hour on a patient, trudging to the next room, spending 20 minutes there. And then at the end of it, you realize nothing has gotten done. All the things you talked about haven't happened. And it's like 2 o'clock in the afternoon. And I think that's something that sometimes, you're inspired by the people you work with to be like them. This was something that inspired me to be not at all like them. That my focus as an attending was going to be on leading rounds that would be very efficient, very quick. And so we could focus on getting to all the things we talked about instead of just talking about them.
I would love for you to unpack that a little bit more because I know that now as an attending, you sort of transitioned from a predominantly academic setting to more of a private practice type setting where you're not necessarily rounding with trainees. And I'm sure that changes your efficiency, changes the speed with which you round, et cetera. Instead of receiving the report from the intern, from the resident, et cetera, you're sort of talking with your colleagues or talking directly with the nurses and putting together the plan. So how would you say that transition was for you? And are there any particular pitfalls and pearls you'd share with the audience in regards to making that transition?
I mean, let me caveat that and say that, we do have residents, we do have med students where I work, but it's less of a focus on the sort of performative aspects of them on rounds. It's much more, a focus on the nursing report and then the, communication of the plan to form a shared mental model. Let me actually kind of back up a little bit and just say that, like, if you want to understand the way rounds are today, you have to kind of imagine like 100+ years ago when Osler and company were rounding. Back in those days, for better or for worse, there was no EHR. So if you wanted to know everything about a patient, somebody had to go all over the hospital to collect this data, right? If you wanted to know what their gram stain showed, you had to go, take their sputum to the Bunsen burner and stain it yourself. If you wanted to know what radiology said, you had to go to radiology, talk to them, put the film up on the scanner. If you wanted to know what their vitals were, you had to go to the bedside, like literally the foot of the bed where the vitals were written down. And so the idea of usually a junior trainee reciting all this information in front of the patient to a group of people, it was actually really important because there was no other place where all that information came together. Right. And so that aspect of rounds was really important a century ago, and I think is largely obsolete today because I can get that same information on my smartphone while I'm getting coffee in the lounge. right? I don't need somebody to spoon feed me the information that I can easily pre-round and get myself. But the purpose of rounds, instead of being just kind of reciting the information, here's the med list, here's the labs, I think that detracts from the more important purpose of rounds, which is to have a shared mental model about who is this person, what is wrong with them, and what are we going to do to fix it.
I think that does a great job of summing up kind of where rounds came from. Maybe helps to elucidate why we hold on to some of those vestiges of the past when we do have those long form, multiple hour sojourns through the ICU, going patient by patient. This whole sort of like dog and pony show almost. There was a time when elements of that were truly necessary as part of the data gathering and kind of data processing. Whereas today, so much information is available in the palm of your hand. So much information is actually, it's already been pre-digested by you or I as the attendings, because we've had access to that information from overnight. And so it's like, why are we necessarily spending so much time reinventing the wheel on every patient, where that time could be better spent in other ways? At least that's kind of what I take away from it.
I think there's also a duplicative problem too, where often, rounds and note sort of converge on one thing. And I think those are actually very different things, right? Like there's stuff that you put in your note that you don't need to say on rounds, and vice versa. And, I think unfortunately we sort of train people to have this view where they have to recite all this information and then they have to recite their note essentially. And I don't think that's good patient care. And I definitely don't think that's respectful of everybody's time when you have multidisciplinary rounds.
So I definitely want to get back to that time element. But before we move on, getting back to my original question, now that you're, perhaps certainly don't want to take away from the teaching that you do in your current job. I know that you are obviously a tremendous educator and you love doing that just like I do. But surely there is a difference now in your practice environment. Can you talk a little bit about that and how that sort of changes the game?
Absolutely. So, I mean, the difference is that, we sort of go into rounds with the expectation that everybody has pre-rounded. I've seen all the patients. I've examined all the patients. I've seen the waveforms and stuff like that. Like I know what's going on with the patients. And so then it's going to be, the nurse sort of presenting the up to the minute data. Um, and then me sort of summarizing concisely what the plan is, and then maybe having some side conversations with the other members of rounds. So, one thing we'll do is we'll have a nutritionist there, we'll have respiratory therapy there, we'll have pharmacy there. So they can sort of, weigh in on points and answer questions immediately. Sometimes we'll have consultants with us. So especially in specialty ICUs, like a neuroscience ICU or cardiac ICU, it's great to have your surgeons or neurologists or cardiologists there so you can make a shared decision together. There's less of a like, I'm going to tell you about this person, and more of a I'm going to tell you what I think about this person approach, I think, in this environment.
And you, I know you primarily work at night, and I think we were talking in pre-recording. Obviously, there's daytime rounds that occur, but then you lead the team through nighttime rounds as well. Is that correct?
Yeah. So I do the occasional day shift, but I mostly do nights. And so when we have rounds at nights, it's kind of like the even faster version of what I try to do during day rounds. During day rounds, we tend to generally have more people on rounds. We have the specialists with us. We have a larger multidisciplinary team. At night, it tends to be a lot smaller. Like it'll be me, charge nurse, and primary nurse. And sometimes that's it. And that's a good recipe for speed and efficiency.
To summarize, it sounds like, Nick, at least in your experience, you would agree that the sort of long form, very, I would say almost theatrical rounds that maybe we're familiar with as trainees from our past probably don't have much of a place in today's ICU versus a more efficient model, whereby the focus is on patient care rather than getting up and reciting, every value over the last 24 hours in sort of this like, again, theatrical way. And it sounds like also in your practice, this is something that's interesting to me, is that you still do round. It's not like you just go room to room, sort of informally see the patient, talk to the nurse, see the patient, talk to the nurse, but there is still somewhat of a rounding process that you go through.
Yeah, I think it's good to have a structure where at a set time you go and you do this because it gives everybody an opportunity to communicate their concerns. It also means that, at a minimum and hopefully a minimum of once per shift, you're having the opportunity to sort of like think collectively and talk through what the plan is going to be and how it has to change. I think that's really important. If you do it informally, I think it's easy to miss that, and people may not feel like they'll have a chance to raise a concern. Or, you may sort of overly rely on your notes to communicate what you're thinking. It's always better to sort of like talk to people about what you're thinking, and then your notes are sort of documenting what you've talked about as opposed to like communicating through the chart, which is suboptimal. But I want to emphasize one thing, which is that just because you're trying to do rounds quickly, and by quickly, to be really clear, I mean like you know ideally like 5-ish minutes or less per patient. Um, sometimes you need more. Sometimes somebody's very complicated. There's a lot of multi-system issues that are interacting with each other. So maybe that person's going to need 10 minutes. But, goal is a few minutes to be really concise, to go in knowing the stuff beforehand. So it's less about being spoon-fed data and more about hearing what every member of the team's concerned about and then formulating a plan that reflects all of that. I think that's the way to reframe rounds. But that doesn't mean that the purpose of rounds isn't educational. It just means the purpose of rounds isn't primarily educational, right? The purpose of rounds is primarily about communicating and coming up with excellent plans for patient care, right? Um, there are still many opportunities to educate on rounds, but it's a different style of education. So, Cyrus, with that being said, how do you approach teaching on rounds if you want to balance time efficiency, but also making it educational for everybody there?
I think that's kind of the $1 million question why we wanted to talk about this with our audience. It's a challenge for sure. When I started, when I was an internal medicine attending, I approached rounds in sort of the more traditional way that I'm used to, the Oslerian approach, if you will, where it's sort of like a lot of teaching, a lot of getting up on stage, so to speak, and showing everyone how much you know is ultimately what I think I was doing as a very young attending. And I still catch myself doing that from time to time. Maybe it's the imposter syndrome. Maybe it's just a lack of, I don't know, a lack of experience or maturity. I don't know, but I still do that from time to time. But what I will say is that I've now developed enough insight to know when I'm doing it and try to peel that back, because I totally agree. Rounds should be about patient care. I had an attending I worked with who said, patient care is done at the bedside. It's not done around a table. It's not done outside the patient's room. And so every minute that we spend hemming and hawing over, you know, this or that is a minute that we could be actually with the patient, caring for them, or potentially with the patient's family. And that's something I think we'll talk about towards the end of this episode, is like, how do we then incorporate family touch points in our day to day? But to get to your question, Nick, I think that over time I've evolved to the following approach. I will usually try to pre-round, of course, and figure out within my census which patient is perhaps the most quote unquote interesting from a physiology or pathophysiology standpoint. And I'll sort of front load that patient to the beginning of rounds, assuming that it's safe to do so. If there's someone who's critical, who's maybe very straightforward but very sick, we're going to talk about that person first. But if we have the flexibility,
and they're often the same, by the way.
Very true. Of course, often the same. But in the event that they're not, we're going to obviously gear the team towards that more critical patient. Anyway, I like to start with the patient that's got some good teaching points first. Give the team a chance to present and show me what they know, and then during rounds at that point in time, when everyone's still fresh, bright-eyed, and bushy-tailed, I may take 5 to maybe even 10 minutes to do a quick chalk talk or just a quick kind of discussion based upon that patient alone. And then we'll proceed, and the goal will then be to shift into efficiency mode. Not to so much, miss things that are relevant to patient care, but I'm going to try to save those teaching pearls for later in the afternoon with the goal of finishing rounds within 2 hours. That's kind of like my time that I set aside for rounding. If we go beyond that, then I'm going to, take the resident aside, get the data from them, and then go through and see those patients on my own just to give the team time to work. I think that at least in my humble estimation, that gives me an opportunity to do a little bit of teaching, to model how to be an educator at the bedside. It's respectful of the team's time. It's respectful of the staff's time. And it gives me a chance to also get through the patients in a reasonable amount of time so that we can get to the actual work of the day, before noon as opposed to 4 p.m.
Exactly. I agree with everything you just said. I mean, I think one of the key things to remember is that it's actually pretty easy to just give a lecture on rounds, but it's very hard to give a very short, concise teaching on a topic. That actually usually requires a bit of pre-planning in order to do that well. And so it's not we're not saying just do the same teaching but faster. It actually is often different teaching, right? You're going to emphasize, some point of physiology on rounds. You have to kind of frame it a little differently if you're doing it at the bedside than if you're doing it when you have a little bit more time and a little bit slightly different space. And I think one of the key things is like, don't necessarily ask like a really broad open-ended read my mind question, but instead focus on I like to do sort of the micro or almost nano teaching at the bedside, like emphasize here's one rare specific med side effect, right? Did you know that amiodarone causes hypotension, but it's actually the diluent, not the drug itself? So if you just run the infusion slower, the hypotension resolves. That's like a micro fact, useful, done. Another, is like, hey, did you know that the Legionella urine antigen is only 70% sensitive? So even if it's negative, it doesn't really change our management. Or let's all gather around and look at this ventilator for a second. There's a really crucial waveform here that we all need to commit to memory, right? Like, look at this work shifting that's happening. Or sometimes it'll be a teaching point. It'll be like, let's all learn how to turn on pulse pressure variation monitoring on this monitor, right? How do you get the machine to show you the QTC dynamically in real time? And that's something where you can do it, I can show it at one, and then as we round, everybody can have a chance to turn it on a different machine, right? And those are great micro teaching points that only take about 30 seconds. And that's the teaching that I aspire to do on rounds. And I try to avoid like the, tell me about this curve, right? There's nothing worse than talking about an equation or something visual when there's nothing visual behind you. Asking people to imagine, Starling curves floating in space is a good recipe for blank stares in my experience.
A lot of times we have post call interns, post call residents, or folks that are on day 10, day 12 of a 13-day stretch, and getting up on the soapbox and spending 30 to 45 minutes talking about Guyton curves and Starling curves and esoteric means to assess alveolar stress on a ventilated patient is probably not it's somewhat disingenuous, to be honest. It's probably not very respectful of the time of your trainees, and also again of the time of the folks that are working on the care team alongside you, who have other patients to care for, other things that they need to get done. Not to say there isn't a place for all that. I think if you're efficient and you're smart about the way you manage your time, you can and should come back to see the patients and see your team later on in the day, do that education. But I've definitely found myself evolving from trying to do all of that during quote unquote teaching rounds to doing that targeted teaching, those little 30-second, 60-second snippets, like you said, and then saving the long form, more traditional lectures for later in the afternoon.
Yeah, I think that's the key. I mean, and often I'm writing down things to talk about later, next to each patient on the list. Like, hey, this interesting point came up, and obviously we weren't going to talk about it there, but let's talk about it now, or let's go back and let's focus on that. The things that I try never to do is, there's nothing more disrespectful of people's time than 5 or 6 people watching me auscultate routine lung sounds. If there's an important physical exam finding that I didn't see in my pre-rounds that I need to see, obviously we're going to go look at it. But, it's just like the goal is to be respectful. And, you mentioned like, if you think about this in terms of like money, right, which is not a great way to think generally, but, for this, it will work. Um, what is the value of time on multidisciplinary rounds? If you have, attending, you have, a fellow, you have several residents, you have, several interns, and then you have, a charge nurse, and then you have all of your other members of that team, right? I mean, the value of that time is immense. Like, thousands of dollars an hour, dollars a minute are being spent by having all those people there. So budget your time as you would the money that time is worth, and spend it carefully. Don't waste that time having people watch you auscultate.
I think that's a great place to end our discussion of sort of how we incorporate teaching into our rounds and how we do that in a mindful way, in a thoughtful way, which I think is really important. Um, I I wanted to incorporate, and I kind of alluded to this earlier. I wanted to incorporate the sort of like how do we connect with family as part of our jobs, as sort of like perhaps the last big thing that we talk about during this sort of brief episode. Um, I think we would both agree, Nick, that that's perhaps one of the most important parts of our jobs is talking to the patient, talking to their family, making sure that they know what's happening so they can make informed decisions in regards to their own care. And so often I find that responsibility being sort of shifted to the nurse, shifted to trainees, because there's not enough time, where we're rushing to get things done. And so the attending's got to go to this meeting, that meeting. And so the trainee can spin the family up and or the nurse can do that. And I'll step in if I absolutely need to. Or alternatively, this pendulum will swing in the far opposite direction. And it's like, okay, we're going to do all of our long form rounds by the patient at the bedside. We're going to go through all of this jargon. Then we're going to define the jargon for the patient and their family. And then we're going to ask them if they have any questions and spend another 10 to 15 minutes going through all of that. So, Nick, how on earth do you efficiently um, address that critically important element of our jobs that is interacting with the patient and interacting with their family?
Yeah, and this is a situation where I think I hold like two completely contradictory views in my head, but they actually kind of meld together. And so on one hand, right, I think having family present for rounds is a good way to communicate. It's a good way to be transparent. It's a good way to show people what we're doing. And I think often families see a lot of people putting their heads together, thinking through problems. And even if they don't understand necessarily all the words, it helps them understand that, number one, maybe the complexity of what's going on. Maybe it takes a village to care for their loved one. And two, uh, it helps them understand that this person's sick. And it also helps them understand that this person is being cared for, right? They see people all doing this. They recognize the hard work that's going into caring for their loved one. So I think all of that is great. What I think is really bad is when people think that talking jargon in front of people is the same as talking to people. And I think people tend to be lazy about having families present on rounds, and they feel like that obviates the need to go back and have conversations with family. Having families standing there on rounds is not a conversation. A conversation should be you mostly listening and letting them do the talking. Having them standing there on rounds is them almost entirely listening. And then maybe some hurried little thing at the end. So I think it's really important to, recognize that having family on rounds good, but that doesn't mean you don't have to go back and talk to every one of those families later. And that, by the way, is a reason to have fast, efficient rounds, because then you have more time to go back and have those conversations.
Nick, I don't know if you share in this opinion or not, but um, two of the things that really drew me to critical care, aside from the physiology and kind of the idea of internal medicine on steroids, two of the really powerful draws were the team-based approach to care with nurses that are really engaged, really involved, able to focus more on that patient. They're not as stretched as thin, really being able to put all our heads together to care for a very sick patient. So that teamwork approach was something that was really, really important to me and was very profound when I was a trainee and drew me into the ICU. The other thing that really clicked with me would be those end of life discussions, those difficult conversations that someone has to have with a patient, with their family. And that has become such an important part of who I am as a clinician, as a caregiver. It has become a big reason why I continue to love critical care is having those conversations, holding a patient's hand, sitting down with their family, crying with a patient, crying with their family. And it just seems so, dare I say, cruel to sort of squeeze that into like an afterthought in between patients that you're trying to round through. And so I just think that if there's anything I can recommend to trainees or other attendings who are kind of struggling with this is like make time for those interactions because that's what the family's going to remember. That's what the patient's going to remember. And frankly, that's what puts humanism in medicine and hopefully is a reason why we're doing this job in the first place.
Absolutely. Yeah, I think that very, very well said. I mean, I think, while family presence on rounds is often necessary for good critical care, it is not sufficient for good family communication. You need to put in that extra time. And I think like you often see people sort of using like that as a crutch, right? Like, we spent 20 minutes rounding on this person, so we spent 20 minutes with the family. No, you spent about 10 seconds actually listening to the family. And maybe you had somebody try to bottom line your conversation about ATN versus AIN to the family, but honestly that's not what the family cares about. The family cares about the big picture. And so, make the time to spend the time with the family where it's going to be valuable time.
That again is kind of foot stomping the idea of being efficient during rounds, making rounds about patient care, making rounds about coming up with the plan or revising the plan, as it were, minimizing
Hmm.
the sort of like hemming and hawing, the pontificating, minimizing the how do I want to say this, the borderline disingenuous interactions with family and exchanging those for quick tidbits of education, high yield topics, and then a sort of afternoon session or a later in the day session where you're going through, catching up with the families, checking on kind of patients, and then sitting down with the team and doing some more formal education if that's what's warranted.
And by the way, one other point here, which is that there is a really valuable sort of skill on rounds, which is sort of like the concise summary. This is kind of like how Chat GPT can summarize a whole document for you in like eighth grade level language. Like, this is a great skill for trainees to learn, right? Which is like, we've just been talking for like 4 minutes about this, right? And then give a 30-second summary to the family, right? You know, we're talking about your loved one's kidneys. It looks like maybe they're getting better, but we're still thinking we might need dialysis. Like, a summary like that in plain language that they can understand, and then give them the opportunity to sort of think about that and say, I'm going to come back in about half an hour when we finish rounds, and then we can talk more about this. Let them crystallize their thoughts and think about what's going on, but don't overload them with all the facts there. And certainly don't, get caught in a big 20-minute conversation about whether the person would want dialysis or not on rounds. That's a bad use of everybody's time.
So Nick, I think we've kind of achieved our goal for this afternoon recording session. We wanted to talk about the philosophy of rounds. We wanted to touch on sort of some of those important elements and how in 2023, almost 2024, we can maybe shift the paradigm a little bit to be more patient centered and provide more high yield, more useful education to our trainees, while also ensuring that family members are taken care of as well. So with that being said, that kind of summary statement, Nick, is there anything else you would want to leave our audience with before we kind of close this out?
I just want to emphasize one last point, which is that I think that some people push back on this and they say, if we have short rounds, when will people learn? And I think there's a false sort of zero sum between learning on rounds or not learning. And I think, just remember, you can do a lot of teaching and a lot of education on rounds, but it's different teaching. And number two, remember that, that all the time that you don't spend on rounds is time you can spend, to add value for patients and their families. So, it's not zero sum. Well, I guess actually that is zero sum, right? Like, you're making time to do a better job teaching later potentially, but also just remember that, like, your goal is not to teach on rounds. Your goal is to teach. And so if that means shorter rounds and more education in other parts of the day, that's a net win.
Nick, I appreciate your insights as always. And not surprisingly, I think we're very much on the same page with all of this. And hopefully our audience will enjoy this discussion. Maybe they'll interact with us via X or through through our website or what have you. We'll make sure that this gets posted for everyone to listen to and enjoy. I think with all that being said, we've come to the part of our show where we want to say thanks. First of all, thanks to the people who left us reviews, comments, or have given us a shout out on social media. We really appreciate your kind words, your suggestions, your feedback. So thank you. Hopefully you guys will enjoy this episode as a little bit of a departure from what we usually do. And also as a response to some of the feedback.
And by the way, let us know what you think of this. If you want to hear more of this, tell us on our website or on social media.
Absolutely. And so with that, again, hope you guys enjoyed the show. If you did, please make sure you subscribe, give us a like, and please leave us a 5-star rating on your favorite podcast app. That helps us tremendously as we want to expand our audience. And it means a lot to Nick and I as well, because this is a passion project of ours that we really care about. Also, of course, you can feel free to reach out to us via X, I guess is what we're supposed to be calling it now.
Still Twitter.
Still Twitter to you. Yep. Never die.
I've literally not updated the app so that it won't even change the icon, which I guess makes me like a little curmudgeonly, but whatever.
I mean, we all choose our hills to die on. So if you want to reach out to us on X or Twitter, we are at Critical Care Time. Also, you can reach out to Nick via at Nick M. Mark or myself at Askins_Razor. And then we've got accounts on Instagram and Threads. That would be critical_care_time, and a YouTube channel as well.
We'd also like to say a big thanks to our sponsor, C-Star Medical. We're very fortunate and grateful that this episode, like all episodes of season 1, are sponsored by C-Star Medical. C-Star Medical is advancing the science of cell-directed extracorporeal therapy to help restore the balance of a dysregulated immune system in acute kidney injury and sepsis. You should check out their website, cstarmedical.com. That's SEAStarmedical.com.
And before we go, we would love to thank all the incredible members of our podcast team for helping make the show possible. Also, our production team over at Podpace, they are awesome. And last but certainly not least, Kurt Belknap, a good friend of ours, who put together this awesome theme music that you got to enjoy at the beginning of the show.
And you're listening to right now, kind of rolling over this as we talk.
Exactly. That's right. And lastly, this podcast and all related media, including but not limited to animations, graphics, and videos, are the property of Critical Care Time. Please share our content near and far. We would love for you to do that. We're all about education, and sharing is, after all, caring. But we just ask that you cite your source.
No stealing. And then final disclaimer, the views expressed within this podcast and any associated media do not necessarily reflect the views of our employers. All references to patients or encounters are modified to be HIPAA compliant, and thus any similarities to real world cases are purely coincidental. Finally, this podcast is for educational and entertainment purposes only and should not be used in lieu of seeking medical advice. With that, thanks for listening. I'm once again Dr. Nick Mark.
And I'm Dr. Cyrus Askin. So long, until next time.